we now move into this current session, which is led by the joint implementation leads, Andrée LeMay and John Gabby, from another ARC, and that ARC is ARC East of England. And their remit is to help us help inform our understanding about how implementation transforms knowledge and the type of skills we need to implement research. So over to Andrée and John, who are going to introduce themselves and deliver their presentation, Tales of the Art and Craft.
What we're going to do today is to talk about the art and craft of implementation, and we've called it Tales of because as you'll see, one of the things that's really important is how people exchange knowledge, and that's often in the form of stories. And ours is a very long story. Andrée and I have been struggling with this problem of how you get research into practice literally for decades, as we'll tell you in a moment. And so this talk is actually, it's a story of our increasing understanding of what it takes to develop the art and craft of implementation and why, and how people actually use knowledge, which will help us to inform how one does that. So we'll first of all start by saying a little bit about who we are and why. I'll ask Andrée to start.
Hey, lovely to see you all, although I can't see you all, but I know you're there. My name's Andrée LeMay, and as you've heard, I work with John as a joint implementation lead for the ARC East of England. But my implementation journey started 35 years ago, almost to the day, when I started work as a specialist nurse for research and development at a district general hospital in the west of London. It soon occurred to me that implementation wasn't quite as simple as a naive 30-year-old was, as I was then, and I learnt a lot. And I've continued to learn a lot and be challenged by the need to implement research and how research transforms as it's implemented. The other things you need to know about me is I've worked with John around communities of practice for the last 25 years, and we've worked in the Clark before the ARC, so in total for about 3 years. So over to you, John.
Yeah, John Gabby, as you know, joint implementation lead. We're also, just in case you're wondering, I'm upstairs in our house and André's downstairs because we've not just worked together for the last 20 years. We came together because I was struggling in a job where I had a real problem. I was running a research program, the Health Technology Assessment Program for the NHS, and at the same time as trying to get all this information that people could be able to use in their practice and in their policy making, I was well aware that they weren't, and I'd been struggling for a very long time to understand how knowledge works. I was ostensibly a professor of public health, but my real interest was always in how to solve this riddle, and started working with Andrée in around 2000 to develop that further. So the research that we've done is pretty eclectic in its theoretical background. I'm not going to read through all these, but just to give you an idea of the very wide range of different theoretical bodies of knowledge that we have drawn on as we've gone on this long journey of trying to understand the way in which knowledge moves. There's an awful lot to take in here, a lot of different theories, and also quite a lot of different methods that we've used. Principally, we've developed around ethnographic methods, but nearly always around case studies, often using action research, almost always being iterative and participative in the work rather than the more positivist approach, always trying to be developmental, and above all, as you'll see, it's a lot about relationships. We regard implementation as a relational process. There have been hundreds of different ways to try and solve this problem of how on earth you get research actually into practice, including things like CPD and education and audit, co-construction, participatory techniques, and various models and frameworks like Paris and Knowledge to Action and the EPIS, and a lot of work around change management, leadership, quality improvement techniques, and so on, not to mention the straightforward directives that you get from the government and from NICE and from policymakers, but still very, very patchy success. So why is that? It should be fairly straightforward. You create knowledge, you validate that knowledge in your research to get robust information, you disseminate that through some kind of knowledge transfer process, and people pick it up and use it, don't they? Well, of course they don't. there are lots of problems with this simplistic, traditional, rational, linear model of research implementation. It's too simple, it's too rational, it's too linear, it's unidirectional, which life isn't. It's individualized rather than collective. It's unproblematized, asocial, acontextual. Otherwise, it's fine. And we owe this slide to a colleague, Hugh Davis.
So we started out in our current job as implementation leads by really trying to work out what are the crucial factors when you come to implementing research. It might seem strange to you, those of you who are with us this morning, that we've swerved from being researchers and trying to understand about implementation to actually doing it. And this is very important because we've been able to take our research into practice, and as you'll see by the end of the presentation, modify and really understand what are the crucial factors. So the first crucial factor that we experienced from our research and also copious readings of the literature over decades is that the context in which you're implementing research is very important. Usually that's the context of organisations, but it may not be. It may be the context of the community as well. After that, the next most important thing would appear to be some sort of understanding of the evidence. What are you putting into practice, into that context, and how relevant is it? You see, from researchers' points of view, we think everything is relevant that we're researching, but from those people who are then going to work with our research findings, they may not be relevant. And so we need to think about the target group as well, the people that we are going to work with, and also the way we're going to work with them. So the last two circles, John, if you could put them on the slide, are the practitioners here, or the people. It doesn't have to be people who are formally seen as practitioners. We call them practitioners here because they are practicing implementation and the change method, the management and facilitation of that change. I just want to put a health warning on here. Putting research into practice, implementation isn't just about taking a change technique, it's much more complicated. So these are the things that we've worked on for a long time, and these are the 4 factors which we and many others think are really now crucial to the success or not of implementation. So today we're going to work with 2 particular themes. First of all, the understanding of how implementation transforms knowledge, and that's really around our research, and then using the right skills to implement research. And again, we're going to draw on some of the work we've done around quality improvement and our own practice as implementers. So the first theme then, understanding how implementation transforms knowledge. So to understand that better, we're going to draw on our stories, our tales are going to draw on these pieces of research. We're not going to go through them bit by bit, don't panic. We're just going to pick from them, and at the end of the presentation you can see references that you can go to if you want to look at them further. But this is to show you that a coherent programme of research underpins the last bit, which is our ARC East of England implementation COPs, which are more about rolling your sleeves up and getting in there and making a difference for real. So the principles of our research, so we'll put them up, we'll unveil them one by one. But before we do that, I ought to say thank you to all those funders, by the way, always desperately polite to do that and the right thing, and I nearly forgot, so thank you there, John. Research uptake is not a linear, rational process. Now, most of you will know that. But when we started looking at the uptake of research, this wasn't actually quite so clear. Policymakers thought that it was linear. It was very easy. We get the researchers to do the research and somehow miraculously it moves forward. And it moves forward through a process of evidence-based practice, evidence-based medicine, nursing, whatever other discipline it is. So in our first piece of work, which was in the very early 2000s, we were asked to design communities of practice so that the people working in what was then called primary care groups could actually implement research into practice. They'd identify a clinical problem, a client-centred problem. They'd move through this very linearised process, and yippee, all would be absolutely wonderful. Of course, sadly for our funders, that wasn't actually what we found. And what we found was that there was nothing linear at all about this process. It was a lot of toing and froing, a lot of altering, a lot of transforming, a lot of ignoring or selecting pieces of research that were useful for practice, of blocking it actively, of adapting it. So it wasn't actually the research that the researchers thought they'd given to people, but an adapted version, and then disseminating that adapted version, and in many instances forgetting all about it as well. So from this we could articulate what we knew already, that not only do people do things slightly differently to the way we'd thought, but also research is not the only sort of knowledge that they use. Research we have to be mindful of, and as researchers it's quite hard to do this. Research has to blend and be adapted to sit also comfortably with policy, protocols, guidelines, theoretical and experiential knowledge, custom and practice, trial and error, all sorts of things. It's only one. As researchers we always think it's the most prominent and we give it primacy, but it's not. And in the studies that we did in the early 2000s, we found all sorts of sources of knowledge and different types of them. And you can see here the myriad sources of evidence that people used. So down the bottom here are the stories and case studies, and that's where we're going to focus on today. And increasingly through the last 20 years, you'll all be aware that of the, if you like, the rise of these sorts of stories and case studies. And they've risen to, from the bottom, if you like, of an evidence-based hierarchy, more towards the top. Because what we've learned when we look at knowledge mobilization and knowledge management literature is the things that stick in people's minds are the stories, not necessarily the methods or the statistics. It's the stories of how people get to where they are and what things mean to them. So the first principle from our research then was research uptake is not linear, and John will go on and describe the next one.
So we've seen that research findings are melded with many other sorts of knowledge. And the reason for that is that people who are making either clinical or policy decisions have to satisfy, which is a nice word invented in the 1950s by a Nobel Prize winner whose name just escapes me at the moment, which is a mixture of satisfying and sufficing. And that's what we do when we make decisions. We do our best. You might think, and again the naive expectation, that you've got an evidence-based innovation which has been suggested and it should simply move through the policy making. This is based on some research we did in a CCG, a clinical commissioning group, and they would take that evidence and they'd build that evidence into their commissioning and into the contracts that they build with the providers, and the evidence-based practice would simply get into use. Well, when we actually studied how that process happens in real life, another messy diagram emerged. And what happened was that as they bounced this around their various committees and their papers that they wrote for each other and the discussions they have and the contractual negotiations and the clinicians and the patients putting in their views, it changed. And not only did the implementation get slowed down and changed, but the actual implemented change that took place was a different shape from that which the research evidence had originally suggested. So the reality is that things always move around because they have to, and the reason for that, and we often call it the implementation game, like a pinball machine, is that when you put your nice spherical steel ball into this machine. It bounces around all these things, and every time it bounces, it goes in a slightly unexpected direction. But worse than that, it changes shape. We sometimes, when we give this talk in the real world, we hand out pieces of potty putty to people and get them to make a shape and pass it along the line to 5 or 6, 8 people further down the line, and it's always changed. And that's exactly what happens, because every time the knowledge comes across a different person with a different set of requirements and a different set of contextual constraints and so on, the knowledge is reshaped and changed. It means something different to different people. And this we in the book we wrote on this, we used an example of some work I'd done 30 years ago or more, where we were trying to get people to improve the treatment of congestive cardiac failure, heart failure, according to evidence, which simply wasn't being done in many hospitals and many community practices. And you'd think it's just a matter, the researchers come up with the evidence and the cardiologists pick it up and use it. But actually, when you begin to look at all the different agencies that are involved in deciding what the local policy should be, whether we've got echocardiographs, what are the local political goals, what do the guidelines say that are sometimes conflicting, what do the research institutions say, the royal colleges, the clinical audit, and so on and so on. And every person who touches that evidence and communicates it to another one is changing it slightly. It means a different thing to a different person. Heart failure to a patient is very different from heart failure to the local finance officer for the CCG who's trying to make budgets meet. So each actor transforms the research-based knowledge. That's the next principle that came out of this story. And that also came out of some work that we did when we were looking at a national program to introduce something that's now very common but was then quite innovative, which was the idea of elective treatment centres. Same blueprint from the American and Australian experience, same edict from the Department of Health that these things should happen, money being made available, pretty much evidence-based. Centres chose themselves to be part of this pilot scheme. We studied, I think it was 16 of them or 8 of them, I can't remember now, I think it was 8, and did case studies of these centres. And the cover of the book really says it all. That because of the environmental uncertainty and change, because of the varied local, internal and external contexts, each treatment centre looked totally different, even though it was supposed to be based for everything from a specialised ward to a spanking new building to just a different way of doing things. So the next principle is that the actors' different understandings and their different needs will always change the outcome of what happens when you try to put that research into practice. As a result of that earlier piece of work with the diagram where all those strange things were happening to the knowledge being bounced around the people developing policy for elderly care, the first slides that Andrée showed you, as a result of that, we were asked to look at what happens in actual practice rather than policy making. And we did some work, an ethnography of a primary care practice, which we called Lawndale, and we checked it out in other practices and in hospital and education as well. And we came up with the idea of what we call mind lines, which are collectively developed constructs of how the guidelines in your head will be actually put into practice. People don't stick to the guidelines as they are published. People meld that knowledge with other things. A mind line is like a big bowl of spaghetti with lots of different things in it, which you have in your head as a practitioner. Yes, you've got the embedded science that you learned when you were at medical school or nursing school. Yes, you've got the guidelines, but you've also got peer values, institutional culture, the behavior of your role models and people whom you respect. You've got just the way we do things around here. We've got what you were taught by your teachers and trainers. We've got your own experience, your tacit experiential knowledge. You've got the practical skills you've developed over many years. You've got the soft skills you've developed, the technical skills. You've got all these sort of shortcuts of ways of quickly getting through the work that you have to do, which various people have called heuristics or illness scripts or rules of thumb. And all of these are blended into your decision making about any particular case, dependent on the situation and the context of that person that you're trying to help. when we ask them where the research evidence is, of course, they don't necessarily quote research evidence. And we were talking here to really top-notch doctors and community nurses who were selected because they were the best in the area for our study. The research evidence isn't explicit. Unfortunately, when we published this paper, we used the word or. We said guidelines or mindlines, and people have therefore often misunderstood what we were saying. It is not a fact that guidelines are used or mindlines are used because they're based on tacit experiential knowledge. The fact is that the guidelines are embedded in the mindlines, and we described in some detail how that happens and how, again, that is being transformed because of all the different kinds of evidence, which include everything on this slide and more. When we were watching them develop their policy, make their clinical decisions, they took account of all of these. Sometimes they'd forgotten what was in the textbooks until you probed and they remembered that, many years ago they'd got this information. Sometimes it was a teaching experience they'd had or a training session they'd been on. Sometimes very often it was talking to colleagues. Central guidance and local guidance played a part. Lots of discussions. There was a they say. We never knew who they was, but they say this is the right way to treat this. This is the drug of choice. This is the person best to refer to in this area. Never quite knew who they was, but they was really important. Again, no mention here of researchers as such, but the research is embedded in a lot of these different sources, even though they may not be aware of it. So we began to liken this to what was then our compost heap. And here's a picture of our old compost heap. And into that compost heap go lots of different kinds of knowledge, evidence, sources of information, of experience, which become melded together from all these different sources. And somehow, by some magical process, like the transformation into compost, which does a lot of important stuff in the garden, that knowledge gets transformed into the mindlines, which does everything that a good clinician does. They don't simply follow a guideline, they build all that into their mindlines. But mindlines are not just an individual thing. We spent a lot of time watching these clinicians chatting together in the coffee room, in the corridor, going across and standing in the doorway of a colleague and talking about their patients, talking about their experience. And we saw them also at their formal meetings when they were putting together their practice policies. We saw how mindlines were exchanged and developed collectively. Mindlines are a collective phenomenon. There's a lot of work in the literature at the moment about disseminated knowledge, disseminated cognition. It's as if there's something ethereal that is shared across many people, which constrains how far you can stray outside the local norms, but gives you the flexibility within that. And this is often shared through telling stories about patients you've seen, the things you've heard, people you've talked to. So mindlines embody that process of transformation, and they are both individual and collective.
So a lot of this goes on in what we call, and other people call, communities of practice. I think you had a session from Sally Kendall on the first day around communities of practice, developing communities of practice within your own ARC community, your research community. And I'm sure if you did attend that, she said what communities of practice were. But for those of you who didn't, I'll just quickly say, for us, communities of practice are times when people who don't normally work together or get together can get together. They can get together to share knowledge, to try to solve problems, to change services, and to learn from each other. They're very lovely definitions by Etienne Wenger, who says it much better than I did just then, but those are the basic principles. And the thing, before I talk about the pros and cons of communities of practice, I'd like you to remember is something that John was beginning to allude to in the last set of slides, and that implementation may be a collective phenomenon. And this is really at the heart of what we do in the East of England. We try to develop communities of practice, to use them as collective phenomena to help us understand and learn from each other how best to implement research. So communities of practice can be helpful in doing a series of things. So John, you're going to unveil all of those things. As I've already said, getting people together. They can implement or reshape knowledge. And this is a really important thing for researchers and implementers to remember. They promote learning by developing and sharing collective mind lines. And that's, I think, what you're hoping to achieve in your communities where you're getting researchers together, the sharing and developing of collective mind lines around research. They are fabulous mechanisms for problem solving and also speedily moving knowledge and innovation into practice, because often, as we've alluded to already, the thing that goes on in community practice is not only learning but storytelling, and they give members ownership of the changes that they're making in practice. And this is critical if you want implementation or anything else to be sustained. People must own it. But they're also not so good at a few things, and they're therefore unhelpful because they can block the spread of knowledge. So you can get in a community and you can get a way of thinking, and that way of thinking will block new knowledge from coming in and altering practice for the better. They can perpetuate bad practice as well as good practice because the community really may not have a mechanism for appraising and sharing ideas. So a community's got to be careful about how it behaves. And so often communities are facilitated so that they can think critically and respectfully about the ideas that are being shared within it. The other thing that's important to know about communities of practice is that they can be naturally occurring or co-constructed. Whether they're natural or co-constructed, facilitated or not, they have a crucial part to play. So we found this from our research. We've also found this from our practice as implementation leads. And the crucial role is in sharing, challenging and accommodating various types of knowledge, that melding that John's already talked about, co-producing agreed ideas for change. And yesterday, I think you had a whole day on co-production. So co-production is really important in building and deploying relationships and ownership. So testing, evaluating and modifying implementation approaches is also one of the jobs that communities of practice can do, because they can set their own success criteria and they can monitor whether or not those are being achieved or not. So we've gone through the first of our main themes today. Now we'll just slide into the second one, using the right skills to implement research. Well, of course, I could spend days and days talking about this, but I'm not going to, you'll be pleased to hear. I'm going to draw on some of the work we did looking at improvement communities of practice, which was funded by the Health Foundation. And this is a report we published in 2014. And then we went on to do some more work, which we've just finished and published a report last year, and hopefully a paper will be coming along soon. So in this particular study, we were looking at quality improvement, and we found that in the main, people involved in quality improvement use three sets of skills: technical skills, soft skills and learning skills. They couldn't be brilliant at just one of these things. They had to have them all, either individually or in their team. And we compared this to a pyramid. And the important thing to remember is if you're going to have a pyramid that stands up and doesn't fall down, you need all of these skills to be at the same level. You can't build one wall of a pyramid and only have half of the other two walls built. It'll just fall down. So we have technical skills, soft skills, learning skills. The only thing that's different when we're thinking about implementation are the specific technical skills that may be used. Sometimes we might use quality improvement skills, but other times we might use technical skills around implementation. And they could be to do with coaching, to do with audit, those sort of skills. There's a lot of overlap between these two disciplines that we don't often make as much of as we could. The soft skills, the people skills, the very hard skills, in fact, are going to be the same. Team skills, leadership, political skills, local knowledge. And the learning skills, again, how to learn from each other, to learn from the organisation as well, to develop organisational learning and to build from that so that you're really producing a very strengthened implementation culture. But what we found was that in this study, of course, context is massively important. So we were watching people working in the health services in Scotland and the UK in this study, and later, in Scotland and England, and in this study there, and in the next study later in England, working in a context which really seemed to be evaporating and changing as they got familiar with it. So it was a bit like you're putting your wonderful bit of knowledge into the implementation machine and it's being chucked around normally, but at super speed because policy is changing every single minute. So the context is needing you to be very adaptable if you're going to get your research into practice. So what we found was in the study on improvement was that there were some particular soft skills, socio-organisational, functional and facilitative skills that were particularly helpful in allowing improvements to be made into practice. And we would suggest now that we could use these skills to also enable implementation to be better enabled in practice. So they were promulgating and adopting the appropriate style and tone. This is very much about leadership in the organisation, leadership in the teams, the communities of practice, where things were changing. We also found something really important about managing what we called the quality improvement, but it could also apply to implementation roller coaster. And this is particularly true now following the beginning of the pandemic, because implementation of many things seems to have racked up to a different pace. It feels like we're being asked to change a lot all the time, but we have to manage that for our own sanity and our own well-being. Getting the problem and the solution right. All too often, research doesn't quite meet the problem that we hoped it would solve. And that's why co-production, again, that you were talking about yesterday, is so important. The co-production between the people who are going to use the solution and the people who are producing the solution, so that a solution can be appropriately produced for the right problem. Communication is always important, getting the right message across. But getting the right message across to different groups of people requires different sorts of communication and really tailoring those communications to those groups. The next one that we found was important was enabling learning. Learning in communities of practice, learning in teams, but also enabling that learning to go beyond the boundaries of those things so that other people could learn from it, to share what was going on in probably not always conventional ways. So by telling stories, by creating illustrations, animations, by doing things in just a different way. And I know that you do some of that already in your ARC through your art-based approaches. And then contextualizing the experience that people were having and understanding that and how that was working in the ever-changing context of health and social care. So those are the things that we found out from that study that allowed us to say, implementing knowledge needs the right sorts of skills.
Just to give an example of this, a piece of work we did in Wales and Scotland about 5 or 6 years ago for the Joseph Rowntree Foundation was working in care homes, and we're running a bit out of time, so I won't do the usual thing I do, which is to ask you to spot the difference between the two pictures. But the difference is that Josh, the guy on the right, is wearing a hat. And that hat was knitted for him by the lady on the left, let's call her Lily, who was one of the residents in one of the care homes, despite the fact that at the beginning they'd both been very sceptical about this whole process. And the whole process was about changing the policy in that care home, which was very much dominated by insurance problems and health and safety problems. Don't pour that tea, lady. It's dangerous. We'll have to get a member of staff to pour it. But I've been pouring tea for 83 years. I'm perfectly capable of doing it, thank you very much. That was the attitude that we were having to deal with, and the evidence from the research and from elsewhere was that that was the wrong way to be dealing with people living in care homes. And we brought together the owners of the care homes, the managers, the researchers, the residents, the relatives, the staff, in a community of practice, and got them to begin to share their experience and their understanding of why that was inappropriate, how to make it appropriate in a way that also didn't mean they had to pay huge insurance premiums and also didn't break any rules. And not only did the care home policy change, but in fact the whole Welsh Government changed its policy about some of these things as a result of getting people to sit down and listen to each other's perspectives. The staff themselves didn't want to do that, and the residents certainly didn't. So it was a way of bringing together their understanding of the context and of the evidence and of the need to make life better for the staff and the residents, and sharing that in a respectful way, in a facilitated way. And the guy, Nick Andrews, who was running this, was the most amazing facilitator who helped that to happen. So we picked up that and used it in our ARC, and we're going to try and finish relatively quickly by explaining how we've done that and give you one example of how it's worked. So the first thing that we've done is to make sure that we select robust research topics from the Clark and the ARC, and sometimes from other NIHR work. And we then form a community of practice with health and social care staff and the organisations and the managers, with the researchers, with public and patients, and with any other local organisations that may have an important part to play in this. And having formed that community of practice, which actually takes a long time, and there's a long design phase as you work out who needs to be involved and why, you get the group to analyse what we call their claims and concerns. So yes, it's a good idea, let's take that previous example, to change our health and safety policy and to be more, and our professionalised behaviour, the rule that says you're never allowed to reveal anything about yourself as a professional, even though people actually want to just chat and talk about their own family experiences. So let's analyse what's good about that, what's bad about that, what would be the boundaries of professional behaviour, what would be the boundaries of safety, and agree an implementation plan. And it's very important to recognise that in a community of practice, it's just the way of doing it to decide what you're going to do, but the actual implementation that you undertake could be to issue a guideline, it could be to introduce a monitoring and audit method, it could be to develop a local collaborative, it could be simply to issue an edict. It doesn't matter what it is, but the important thing is that the community of practice have agreed that plan and set their success criteria. We do use the methods from quality improvement, particularly PDSA, for those of you familiar with it, Plan, Do, Study, Act, these cycles of small tests of change to develop things as they go along. This is not a research project where you try something and you have to be faithful to it and you test fidelity. This is something where you learn from experience as you go along and you adapt. So the change gets implemented slowly, and if it has been successful, then our principle is to roll out successful changes. And we're also trying to train people in the ARC to learn these methods. And finally, of course, you learn a lot from that process, and you can then feed that back for further research into some of the things. That requires, at the bottom there, the evaluation, both formative and summative, of the structures, processes and outcomes of this whole process. So we've done this so far with 6 communities of practice. I don't know whether you know, but in east of England we have what we call populations in focus, which are basically deprived areas within East Anglia. It's not all fancy Cambridge. And those populations in focus are involved in a lot of the research that's going on in the ARC, and we try to do our implementation work there as well. 2 I'm going to pick out of these because we're running out of time. One is something called positive behavioural support, which I'll come back to, which is basically about supporting young people with really difficult, challenging behaviour who are normally sent away to one of those institutions which you may have seen on panorama programmes, or preferably better ones than that. But that sort of long distance, extremely expensive and not very pleasant experience for the family, for the young person themselves, or indeed for the staff. You can get around that by providing better support at home, and we were trying to introduce that in one of our populations in focus. And the other one was trying to completely reformulate the care for children and young people with mental health problems, so that it can get rid of the really rather long waiting lists and other problems that there have been there. I'm going to quickly talk about that latter one. This is a trust, a mental health trust, who has been struggling with this problem for 15 or 20 years now, who asked us to come in and help. And what we did was to spend quite a long time, as I suggested on the previous slide, bringing together all the right people, and also including people outside the CAMS services, the Children and Adult Mental Health Services, from the voluntary sector, from the local authority, and so on, and try to get them to recognise the coincidence between what they were really wanting to do as opposed to what they were forced to do by the local context and circumstance, and the methods developed at the Anna Freud Centre in London, which is called Thrive. iThrive is implementing Thrive, and Thrive is about reconfiguring the service so that it's not based on how serious the problem is, but it's based on what kind of help you need when, and on who can give it, and on trusting the different bits of the partnership to work together to allow each other to take things instead of referring every time to another part, which then makes the young person have to wait several weeks or months in order to enter that different part of the system. You trust whoever is dealing with the child, so it's no saying no to somebody when they come to the service. You'll have to wait. You do what you can and what you're able to do, and you trust each other to do that. And it's a whole different way of doing things, pretty solidly evidence-based. And we've now got to the situation where there are groups of people working together to try to implement this really fundamental change in the way the service is happening, without really needing any particular input of extra resource at the moment. So the lessons from this relational work is that it does take a lot of preparatory work, and that once you get going, you can actually go through the community of practice work relatively fast. We started working on this a year ago, but we only started the communities of practice at Christmas, just before Christmas, and things are already beginning to change quite significantly with much more collaborative working. People have been very willing to engage in this work over the ARC. We've had well over 100 participants, and it's all really fundamentally reliant on this development of relationships and the facilitation of what we call respectful critical dialogue. It can be quite robust, that dialogue. It's not all touchy-feely stuff. You can be pretty robust, but you have to respect each other's views, and across sectors. Fortunately, with the pandemic, we found that we could run communities of practice by Zoom, which was a bit of a relief, because all the ones in that last one I was telling you about have taken place on Zoom. We haven't actually met most of the people physically. And it's all about contextualizing knowledge. It's all about making sure that it fits into the local complex context of the sorts that we've been telling you about throughout this talk. And a small input can make a very big difference. We held 3 communities of practice around this positive behavioural support project I was talking about earlier. And they have now instituted that in Peterborough and Cambridge, where it was already beginning to happen. And the economic evaluation that's been done by our health economics bit of the ARC suggests that they will be making a saving of between 1.3 and 2.2 million pounds a year as a result of introducing this, and improving the quality for the young people and their families. We have had an external evaluation of the whole process, which you can have a look on online if you like to see how this has worked across all the communities of practice.
So the principles then from our interventional or implementation work are simple. Include all relevant parties. Develop relationships and share perspectives, and use these respectful, critical conversations that we've been talking about. Maximise all relevant skills needed to make the changes, and make sure that you have a team of people or teams of people who are able to fulfil that very broad skill set. Analyse and deal collectively with claims and concerns so everybody feels comfortable, and facilitate skillfully to get consensus on desired, soundly based change. Once the design work's been done, and as John's already said, it's often quite a long process, we need to move fast, gather people together into communities of practice, use small tests of change, or whatever that community thinks will be helpful in moving forward. And sometimes that's to move to more formal structures of groups that have terms of reference and task and finish groups, and then share the results of the change across all the relevant parties and beyond. So that's really the end of our talk, but before we do finish, we need to thank all our co-researchers who've, we couldn't have done this without them, and the participants in our various studies and the COPs we're working with at the moment, and of course to thank you as well.